So today's talk is part of the STEP Family and Community Workshop series and is hosted by the STEP Clinic, the STEP Learning Collaborative, as well as the Connecting to Care initiative. And we're joined by a couple Connecting to Care representatives today, Jules Calibro, and I think some other folks who will be attending. So I'll start by introducing myself as well. Just a word on Connecting to Care. It's a partnership that strives to build a system or network of care that meets the behavioral health needs of all children in our state. I'll start by introducing myself. I'm Dr. Laura Yovine Sykes. I'm a clinical psychologist at the STEP program, which is a specialized outpatient treatment program for young adults with early psychosis in the greater New Haven area. I'm also the director of our STEP Learning Collaborative, which is a statewide initiative to promote workforce development and community and family engagement in Connecticut in order to better serve young people and families that might be impacted by early psychosis. In addition to my professional roles in this area, I also identify as a family member of someone with schizophrenia. So I'm really grateful to be able to be in this position to talk with you all today. My co-presenter today is Will Kohler. He's a clinical psychology graduate student at Yale and an expert clinician at the STEP Clinic. He's been co-leading the dissemination of our family service offerings at STEP, and he's also researching memory and learning and how that relates to schizophrenia spectrum disorders. We recognize that we have an audience coming from varying backgrounds and experiences with early psychosis today. Some of you might be family members of young people that are experiencing psychosis, and you might be in various places of this journey. Maybe someone who's newly diagnosed, might be in the position of being someone who's just feeling really desperate to try to connect a loved one to care. Or perhaps some of you are just interested community members looking to become more informed about recognizing the signs of early psychosis. We also might have some young people or family members that have their own lived experience of psychosis in the audience today. And, so recognizing that we've got a wide audience and everyone's welcome here. So whatever brings you here tonight, we want to thank you for your time and we hope that you find this helpful. So I'm going to hand it over to Will now to walk us through some basic psychoeducation.
Yeah, so we're going to start by just talking a little bit about what psychosis is and what it isn't, a term that we're going to be talking about a lot today. And there's a lot of different ideas about what psychosis might be. To begin with, psychosis is not a diagnosis in and of itself. Rather, it's an umbrella term that describes a set of experiences in which people have difficulty telling what's real and what's not real. So psychosis can include disturbances in perception, which are known as hallucinations. It can include unusual beliefs that are sort of out of sync with other people around you, known as delusions. And it can also be characterized by disorganized speech or thought patterns, which we refer to as thought disorder. And thinking about, who experiences psychosis, it's a lot more common than you might think. So in fact, 3 in every 100 people will experience psychosis in their lifetime. And so just like taking a second to think about that in the context of our lives, if you have 300 friends on Facebook, that's 9 people that are likely to experience psychosis at some point in their lifetime. So it is a much more common thing than a lot of people give it credit for. Psychosis also doesn't discriminate, right? It can impact any race, gender, sexual orientation, religion, or socioeconomic class. And psychosis usually develops in adolescence and in young adulthood, around ages 16 to 35. Although the onset tends to be earlier in young men and a little bit later in women. The peak age of incidence for psychosis is around 21 years old, which is kind of the age range that we're going to focus our discussion on today. First episode psychosis simply refers to the first time that someone experiences psychotic symptoms or a psychotic episode. And, I think it's important to consider that people experiencing a first episode may not understand what's happening. The symptoms can be highly disturbing and unfamiliar, and they can leave the person confused and distressed. This is also often the case for family members or other loved ones who may be equally or even more bewildered at what's going on. And so at STEP, we focus on the first 3 years since onset of full psychotic symptoms. And I think that in this period, it's important to kind of recognize the uncertainty and the ambiguity that comes with kind of figuring out what's going on. And so we often talk about diagnostic ambiguity, or this kind of uncertainty about the specific term that best fits a person's experience. And so this is an expected part of early psychosis treatment because there are many different causes of psychosis. So we're kind of aiming to identify first episode schizophrenia, but psychosis also has many other causes, many other reasons that people could be experiencing something like psychosis. Think about those causes of psychosis. There are a lot of them. And I think it's important to remember here that psychosis itself is not a diagnosis, but rather a way of describing experiences that deal with this difficulty in reality testing and telling what's real and what's not. So, for example, psychosis can occur in extreme states like extreme sensory deprivation or lack of sleep. So, if any of us didn't sleep for a week, we would probably start to experience some aspects of psychosis. We might see things that aren't there. We might hear things that aren't there. Most commonly, however, psychosis occurs within the context of mental illnesses. So this could be a schizophrenia or schizoaffective disorder, but also mood disorders like bipolar depression. This is less common, but psychosis can also be secondary to medical conditions like Parkinson's disease or epilepsy or some forms of brain damage. And then finally, substances can induce psychosis. So psychosis can occur when someone is acutely intoxicated on a substance like cannabis or LSD or stimulants. And so again, this is kind of like pointing to the fact that there's a lot of potential causes of psychosis. And so some of what we're doing in these first 3 years of treatment is trying to figure out what's giving rise to these experiences. Thinking about some of the common signs and symptoms, the different domains of psychosis, perhaps the most recognizable set of symptoms are called positive symptoms. And when we say positive symptoms, we don't mean positive as in good. We mean positive as in they sort of add something on top of normal experience or distort an individual's experience. And so this can include things like hallucinations or delusions. So hallucinations typically involve usually hearing or seeing, but sometimes tasting or smelling things that aren't there. This could be indistinct noises, colors, and shapes, or it could be something as clear as hearing a voice or seeing someone who isn't actually there. Delusions can also take a number of forms. They often include believing things that aren't true or are unrealistic, or may even be impossible. Some of these are kind of bizarre in content. They could be about an alien implanting something into my brain, and some of them are focused on things that may be more everyday worries, like other people's appraisals of you, or other people making fun of you, or wanting to hurt you, or your partner cheating on you. And I think that's important to recognize here that an inherent part of psychosis is that many folks will have what we call limited insight, which is essentially meaning that it's hard to tell what's real and what's not. And there's a kind of a lack of awareness that they might be experiencing things that other people aren't experiencing or don't believe are real in the same way. And I think it's really important to consider that these experiences feel real in the moment to the person experiencing them. And people are doing their best to make sense of a confusing experience. And this can be something that is particularly challenging for family members and providers alike, trying to come to a common understanding of what's going on during this confusing time. Another set of symptoms that is commonly seen in psychosis is called negative symptoms. And so contrary to positive symptoms like hallucinations and delusions, negative symptoms show a kind of reduction in or loss in normal perception, behavior, and functioning. And so this could include things like decreased motivation, decreased energy, a lack of enjoyment in things that people usually enjoy, less perhaps interest or involvement in life at the home or outside of the home. It can also involve difficulty with schoolwork and paying less attention to personal appearance and hygiene. And then people may also experience cognitive symptoms. So this could look like difficulty concentrating, people appearing more distracted or having a harder time planning and remembering. And then finally, folks experiencing psychosis also have frequent fluctuations in their mood, which could look like anxiety, depression, or suicidal thoughts.
Thank you so much, Will, for walking us through that. Now that we've covered some of, some terminology and some understanding of the different types of symptom domains that we commonly see in schizophrenia, I want to talk about what the course of schizophrenia might look like. So although schizophrenia, so now you can notice I'm talking about a specific diagnosis here, not just the experience of psychosis. Schizophrenia is a heterogeneous illness, meaning no people are going to have the exact same experience. And so this slide does its best to represent a typical course. So here on the x-axis, we've got age, and then on the y-axis, we have level of functioning. Most people who go on to develop schizophrenia were functioning typically when they were young. So here that's the kind of pre-morbid or green box. Then usually around adolescence, as Will mentioned, maybe something begins to change. Folks might maybe start to experience some depression, some trouble concentrating, even what we'd call kind of low level or subclinical or attenuated psychotic-like symptoms. So maybe they start hearing noises that they recognize aren't real, but they're catching their attention and making them wonder a little bit. Maybe If we were in this stage, we might start feeling a little suspicious or paranoid about others, but are able to easily kind of dismiss what those concerns. We might have trouble thinking as clearly as we used to. So this is known as the prodromal period. And that's often a couple year period, 1 to 3 years typically, that would precede the onset of kind of full symptoms of psychosis. And so at this time, this kind of juncture here, where we go from the beige to the red box, that's where we would see that kind of first episode of psychosis. And that would be the kind of point in time when there's usually a more dramatic decrease in someone's functioning. Maybe they end up kind of needing to take a break from work or school, or a psychiatric hospitalization occurs. These symptoms kind of these experiences become so intense that maybe they're really, interfering with someone's functioning significantly and causing a significant amount of distress for the individual. With treatment, it's important to recognize that most folks who have these experiences can show recovery, can have success, whatever that might mean to that individual, whether that's meaningful relationships, marriages, children, meaningful work engagement, whatever that might mean. Folks who experience schizophrenia can absolutely live successful, meaningful lives. This is not meant to be some type of some death sentence or some of the stigmatized things that we might hear about when perhaps we first think of this label. But it is something that generally does require treatment. You can see kind of if left untreated, most folks who have an episode of psychosis will tend to have recurrent episodes and a bit of a decline in their functioning. However, as I'll talk about later on, the earlier we're able to intervene with effective treatments, the less impactful these experiences will be on someone's kind of life trajectory. Why is treating psychosis important? Right? Particularly if this audience is full of family members or individuals with their own lived experience today. I don't need to preach this to you, but we're going to share some of this information anyway. There's a significant impact on the individual who is having these experiences, as well as their family or the support of folks around them. If left kind of untreated, psychosis often leads to frequent hospitalizations and can derail functioning for folks at a particularly critical juncture in that kind of young adulthood timeframe. So it could kind of get in the way of school, career, or family pursuits. It is important to mention that there is a significant, risk of suicide with folks experiencing a first episode of psychosis. Approximately 1 in 100 folks with this experience will die by suicide, and as many as 10% might attempt suicide within the first 5 years of having these experiences. So I know that can be a heavy stat to sit with and to think about, particularly as we're maybe thinking about our own experiences or thinking about our loved ones. But all the more reason, to try to do what we can to detect these experiences early and try to support and encourage treatment for those that we care about and for ourselves. Additionally, there are some additional health risks that folks might experience if left untreated. So that's just thinking about the individual. And then of course there's a significant family and caregiver impact of just the the emotional toll that it can take, as well as more practical logistic things of kind of time off work or things like that to kind of support and care for someone who might be struggling in this way. So we already talked about the risk of suicide. I want to just spend a minute talking about the risk of violence and really emphasize this here, that the majority of people experiencing schizophrenia are not violent. In fact, people with schizophrenia in the community are 14 times more likely to actually be the victims of a violent crime than arrested for one, right? So this is much different than what we hear in the media and kind of perhaps some of the stigma that can be associated with this label. And what we do know about an individual's risk for being aggressive or violent in schizophrenia is that it's highest when folks are not connected to treatment, or treatment is delayed or inadequate, and when there's kind of comorbid substance use going on during this initial episode. As I mentioned, there is risk for victimization and things like that, is more so than folks actually being perpetrators of violence. So to do a little bit of kind of myth busting, particularly as community members or folks who might be feeling stigmatized themselves, recognizing that certainly not everything we see in the media is capturing the full picture here. What should I look for? What are some of the common signs of young people at risk for psychosis? Can be a little bit of an overwhelming slide. Common signs of young people at risk. A lot of different areas that we already mentioned. There could be some of those subtle mood-related symptoms. I just want to draw our attention. Cognitive changes is one. This is one that I've seen a lot as a clinician who has worked both in the kind of care for folks who are at clinical high risk or the prodrome, as well as folks who are experiencing full symptoms of psychosis. A lot of times we might have family members or young people kind of coming in and saying, you know what, my young person's got late onset ADHD. And I really talk a lot, especially to providers, about that being kind of a red flag of what we know about ADHD. Of course, diagnoses and things can be missed, but we know that it needs to kind of be present from early childhood. And so when I see people kind of saying that they're having new onset concentration difficulties, I'm not saying that that's not true. What they're experiencing isn't real or valid. As Will mentioned, there are cognitive changes that can occur. But the consideration of psychosis and considering, is this ADHD, is this depression, should be in the conversation, because particularly because if stimulants are prescribed when someone's having an emerging psychotic disorder, that can actually exacerbate some of the symptoms of psychosis that they might be at risk for. And then we do often see, which is often more noticeable to teachers, to family members too, especially if folks are being, they're containing some of these experiences, they're not feeling comfortable sharing them. What we might see outwardly is maybe a decline in grades or social withdrawal from someone who used to be more outgoing and have a friend group, or maybe some kind of odd behavior. That is a change. The biggest thing is noticing a change for the young person in your life, right? So not do they have any one of these, because I think any of us could endorse at least some of these symptoms with or without a diagnosis, but recognizing things that are a change for that individual. They used to kind of, be really social, and now all of a sudden they're not. The grades used to be good, and now there's a decline. They used to be able to concentrate, now they're not. So recognizing changes, particularly in that adolescent timeframe. So what contributes to the development of psychosis? Why does this happen? And we could spend a whole hour, certainly talking about this, but hitting on this quickly, it's complex. There's no single factor that has been identified to cause psychosis. Rather, it's a number of factors that interact to contribute to its development. So we'd like to think about the stress, vulnerability, illness model, and this notion that some folks may have some type of genetic or early predisposition for developing psychosis that can interact with environmental stress that brings about the experience of psychosis or the exacerbation of symptoms. And I don't want to get kind of too academic here, but just showing a little bit and highlighting some of the risk factors. Again, none of these are anyone's fault. Often it's not preventable. There is genetic heritability. So there is increased risk if there is a family history of someone having experience of psychosis. So having a first degree relative changes that from that kind of 1 in 100, percentage to kind of 6 to 13 times more likely. So still, even though there's a family history, that is absolutely not a guarantee. That's not 100% concordance. That's saying up to about 13%. Early experiences of trauma kind of put someone at increased risks of developing psychosis. And we do see that there's substantially higher proportions of PTSD in individuals with psychosis than the general population. Again, just highlighting this to show that it's a risk factor, but in no way is this a guarantee. Not everyone who goes on to develop schizophrenia had experienced childhood abuse, and vice versa. Not everyone who had some type of adverse traumatic experience in childhood will go on to develop schizophrenia. Something I really want to highlight it's just really relevant nowadays, is the substance use component, particularly in late childhood and adolescence. With the legalization of cannabis, it's so important that we recognize the risks that this can have, especially related to psychosis. So Adolescent cannabis exposure is connected with 2 to 4 times more likelihood of developing a schizophrenia spectrum disorder. That's not just, oh, someone used one time and so now they're 2 to 4 times more likely. There's a relationship with the greater frequency of someone's use, the longer duration, as well as the earlier first use. So, if someone started at regular cannabis use at 12 versus 18, that individual is going to be at higher risk of developing psychosis than someone who started much later. Also really important to recognize that the cannabis that's going around within the past 10 years has much higher potency THC, or that psychoactive component, than it used to be many decades ago. And so that as well puts someone at greater risk. And so kind of thinking about the THC to CBD concentrations and ratios in the cannabis that folks are using is an important factor. So we really talk a lot, to our clients and in our outreach about trying to minimize the use of cannabis for folks who might be at risk for psychosis, as well as those folks who already have an established psychotic experience. So even if someone, Will had mentioned that some causes of psychosis can be substance induced, we do know that even if someone's initial experience of psychosis was due to substances, they are more at risk for having a subsequent episode, even if they're not using later on. So it kind of triggers some type of vulnerability. We're still trying to understand all the mechanisms at play, but in general, we really recommend limited use of cannabis. Wanted to talk a little bit more about examples of positive symptoms. So I know Will already, shared a little bit about some of our common experiences of psychosis, hallucinations, delusions, paranoia, different things. I wanted to just put some more examples to some of these experiences and take a closer look. So it's important to recognize that all the experiences of psychosis and that I'm going to demonstrate here occur on a spectrum, ranging from typical normal range, which anyone who may or may, might not have an experience of psychosis might experience, to that kind of prodromal or clinical high risk attenuated middle range, to experiences of full psychosis. So I'll talk through just a couple. A really subtle early sign might be someone saying, having a hard time telling what was in my dream and what was real. Again, that doesn't necessarily have to be pathologized. That could be something that is commonly said, but with folks maybe starting to experience psychosis, we might hear comments like that more frequently, and then they become more distressing. We also hear from folks that everything has started to sound too loud and too close. It's like I can hear everything at once. Not everyone is going to experience all of these symptoms, but that can be an example there of how there can be changes in what we call kind of sensory gating, or the brain's ability to kind of filter out salient or relevant information. And all of a sudden a kind of change starts to happen where everything starts flooding in. That kind of filter is no longer working as well as it used to. And of course you want to be, someone who's maybe long-term had some sensory sensitivities or things like that. Maybe that's always their experience, or they're just someone who's sensitive to external stimuli. And that wouldn't be something that we would want to necessarily consider for psychosis. But again, if it was a new experience for someone, say in adolescence, it could be an early sign that something's going on. Subtle signs, I keep seeing blue cars. I wonder if that's a sign I should pay attention to. I think about it a lot. So maybe like an early, what we would eventually call, if it progressed, like an idea of reference. So kind of noticing something in the environment that is really sparking someone's interest and consuming a good amount of their time. Again, more kind of subtle attenuated symptoms. I'm not talking about full symptoms of psychosis yet, but every time I hear my classmates laughing in the hall, I'm pretty certain it's about me, right? So maybe there you start to see some subtle signs of suspiciousness or paranoia. And always with this one, and I don't expect family members to always be able to make this differentiation, but as providers, here, I'm thinking about, okay, is this a person experiencing like developmentally normal self-consciousness in adolescence or some social anxiety, or is there feeling like, and it's more about like being socially evaluated, or is there an interpretation of more malintent of like, I think people are laughing about me because they're out to get me in some way, right? That's kind of a bit more in the paranoia spectrum. Sometimes I feel like my thoughts are being broadcast out loud for everyone to hear, so that's why I don't leave my house, right? Another, experience that we might hear. Getting a bit more defined now, maybe someone might share something like Eminem is sending me coded messages through his songs, and you know what, Dr. Sykes, it's because I'm famous too. Sometimes I can impact people's emotions with my thoughts. It's a special gift. So we often see folks kind of maybe having some grandiose beliefs or feelings of kind of special powers or gifts that they didn't previously have. Additional examples of suspiciousness. Maybe I feel like my family is tracking my every move and thought. And when you ask them a little bit more about it, their conclusion is actually that not just someone's tracking their phone and all the apps that we can do these days, but that they must have put a chip in my head when I was sleeping. And there you kind of get into a bit more concern for psychotic interpretation of things. And then, of course, there can be perceptual experiences that can go on to be full hallucinatory experiences of voices or visions. And sometimes these can even be command in nature. They tell me I'm no good and that I should hurt myself. I just share these to kind of show that there's a wide range of different positive experiences. And again, many of the ones that I just mentioned here are actually more attenuated, low-level experiences. And any of these you'd want to train professional to try to kind of ask a little bit more and understand the impact that any of these thoughts and experiences are having on the person, because just because they're having a thought like this doesn't necessarily mean that it's problematic. So I do want to share, a little bit more to just hammer home the point of like differentiating how symptoms do occur on a continuum. For any, providers in the room, this is actually an example from one of the assessments that we frequently administer for folks who there's concern or suspicion of experiences of psychosis, called the SIPS. This is an example question. Have you ever found yourself feeling suspicious or mistrustful of other people? So someone who might answer in the more normal or typical range might respond, I don't completely trust my new roommate, but my mom told me not to trust people right away anyway, right? So pretty common response, perhaps. Somewhat a response in the clinical high risk range. Again, so kind of risk for psychosis, or like psychosis that's kind of in remission, but still, lingering a little bit, might be, I think my roommate might be poisoning my food in the fridge. And sometimes I even throw it out just in case, but I'm probably just being paranoid. So there you've got this compelling thought that someone might be poisoning them. It results in someone like changing their behavior, throwing it out sometimes, but then they're able to spontaneously kind of question in themselves, like, you know what, I'm probably just being paranoid. And it turns out when you ask a little bit more, it's not significantly impacting them all the time. And it's not terribly distressing, although it is on their mind. But then when someone is experiencing what we'd consider kind of full psychosis, maybe they would respond in this way. I'm certain that my roommate is out to get me and is poisoning my food. Sometimes I don't eat for days, right? So you can kind of see the difference there, that there's a level of certainty and significant impact on someone's functioning due to these beliefs and experiences that could even put them in danger, right? If someone's not eating for days, you might be concerned that they're actually maybe even in need of a hospitalization because they're maybe losing so much weight or so malnourished that their physical health might be in jeopardy. It's certainly not always the case. People every day live their lives with experiences on various parts of this spectrum. So just because someone is experiencing a symptom of what we would say full psychosis or frank psychosis, where they're fully convinced of something that might not be real, it doesn't necessarily mean they, need to be in the hospital or things like that. But the times when it is impacting their physical health in a significant way or putting them at risk for hurting themselves or others, those are times when something like a hospitalization would be required. But certainly psychological and possibly psychopharmacological, so medication treatment, is absolutely could be indicated for folks on this spectrum and can be very helpful for managing these experiences and preventing them from getting worse. So how to ask about symptoms of psychosis. I'm not going to, some of this is a bit more, relevant towards providers or folks in the school setting who are kind of wondering, but it can be applicable for family members too, who are maybe wondering if they're starting to notice some of these subtle signs. And we'll go a lot more into this at our next offering in April. But some general strategies is like asking soft questions, being patient with folks, trying to normalize, and really, I want to emphasize here, being curious with your questions, trying not to overreact if someone is sharing with you that they're having some of these experiences that might be related to psychosis. Again, we also want to consider cultural explanations for things. So if someone's coming up to me and they're sharing with me that they're, having the experience of seeing ghosts in their house, I'm not going to immediately say, oh, this person's having visual hallucinations and they have psychosis and they need treatment. I want to understand if that's typical for them, how their family views that, how their religion views that. This at times can get tricky. And again, usually involves a kind of a thorough assessment by a professional, but where you would notice, so maybe someone says, oh, this is like completely typical in my family and I've been like this my whole life. So there I might not say that there's anything of concern. But if someone came to me and said, I'm hearing and seeing ghosts and no one else in my family does, and it's actually really distressing to me and it's preoccupying my mind all the time and it didn't used to be like this, or the individual's beliefs kind of really go above and beyond that of their family or their subculture, that's when I'm going to be, more concerned and think, okay, so even though this could be a really, valid and culturally acceptable experience, it seems like it's having a significant impact on this person. And so I want to take a closer look to understand if something more is going on. Also really important for families and anyone kind of interacting with someone who might be experiencing psychosis is that it's important that we don't argue or dispute what might be delusional beliefs. So quickly explaining what this might look like. Someone might feel like they're being followed by the CIA, and then perhaps you're talking with them and in your mind you're like, this is just absolutely not true. You try to tell them like that's preposterous, there's no one following you, can't you just believe me? That approach is generally not going to work. In fact, it's going to make things often worse and kind of lead to kind of some more distress in that moment. A better response could be, validating the underlying feelings. Wow, that sounds like that must be really, I imagine that's really scary to feel like someone's following you or to feel like your privacy is being invaded, and so you're just kind of validating, you're not agreeing with what they're saying if you don't agree, but you're able to kind of connect and help someone feel understood. Because to that individual, that experience feels very real and the emotions related to it are very real. So as I mentioned on that kind of course of schizophrenia slide, the earlier that we can intervene with effective treatment, the better. Reducing the delay to treatment after someone has started experiencing psychosis is associated with much, with better outcomes. We see clinical, functional, and cognitive benefits for individuals who get connected to early intervention services. And kind of getting someone connected to treatment can help reduce the consequences that psychosis might have. And those are some of those risks that I mentioned. Risk for kind of harm towards self or others, risk of homelessness, of kind of being unemployed or disconnected from relationships. Treatment works, it's very effective. And so kind of getting folks connected to it can be really life-changing. Perhaps you've already contacted us, perhaps you're already contacting other folks in your area, but if you're one of those kind of just concerned community members looking to learn a little bit more, if you see the signs of psychosis in someone then they need your help them contact their doctor or local mental health provider.
So now we're going to get into some myth busting, and I think a lot of this is kind of summarizing what you guys what we've been kind of talking about today. And I hope that coming out of this, conversation and given your experiences, that you all feel empowered to bust these myths when you see them out there in the world or in your own life. So to start with, there's this common myth, right, that psychosis is really rare. No one in my life will be impacted by psychosis. And in fact, as we mentioned before, psychosis is much more common than you might think. So it's that stat, right? 3 in 100 people will experience psychosis. That's a lot of people. And this is cutting across race, gender, sexuality, religion, and socioeconomic status. So it really can affect anyone. The next myth that I think is stuck around, is really persistent, is that this idea that treatment doesn't work for psychosis, that you can't treat schizophrenia. In fact, treatment is effective. People with psychosis can and do go on to live successful and meaningful lives. And importantly, as Dr. Sykes was highlighting before, the sooner that treatment is started, the better the recovery. Yeah, these things are treatable, and there's lots of examples of people thriving with psychosis. Next, these kind of two related myths, right? That treatment is scary and painful, or that treatment means being locked up in a hospital. I think here it's important to kind of like dismiss some of those tropes that you see in media or in movies. Don't believe the scary things they see in the movies, right? Treatment is indeed safe, and it typically consists of medication and psychosocial therapies. And so, in the same way that if you're experiencing depression, you might go in and talk about your thoughts and feelings and figure out tools to deal with that. It's very similar tools are effective in working with psychosis as well. And speaking to that piece of hospitalization, in fact, early treatment most often happens in an office, where the patient comes in for treatment and then goes home again. And it's only in those most severe circumstances where someone is at risk of hurting themselves or hurting others that hospitalization is indicated. And then, as we've been saying, right, this myth that people with psychosis are violent and dangerous, when in fact, we know that people with schizophrenia are actually 14 times more likely to be hurt by violence than to be the perpetrators of violence. And I think that this is a really important one to sit with, because it highlights the importance of understanding psychosis, because I think a lot of that violence can be driven by people not understanding what's going on with someone, or if someone's acting in a way that is strange, people become scared by that, et cetera. And so I think that part of the goal of understanding what psychosis is also helping to reduce instances of violence like this. And then finally, I think this is a really important myth to bust as well. Psychosis is due to a lack of willpower and doesn't require treatment. But in fact, we know that psychosis is a brain disorder. And there are many young people and those around them that ignore the symptoms of psychosis and avoid getting the necessary treatment. And I think that this little cartoon kind of highlights how ridiculous this mindset is in some ways, right? It's here this person saying to someone with a broken leg, "We just need to change your frame of mind, then you'll feel better." And I think that people feel much more comfortable saying that type of thing to people who are suffering from an illness that's less visible or looks less physical in nature. And there can be this sense of, if you just change your frame of mind, then you'll feel better. And so I think that is a really important one to work around, because it can create barriers to people getting into getting the treatment that they need. And with that, I will pass it back to Dr. Sykes to wrap up.
Thank you, Will. So, just another call to kind of action. And again, perhaps many of you have already taken this, but what to do if you see the signs, help someone kind of get in contact, whether it's, ideally you're finding some, a mental health agency, but even kind of getting in touch with primary care or a doctor, and bust some of the kind of stigma that, again, Will mentioned might prevent folks from disclosing these experiences or getting treatment, knowing that psychosis is treatable, it's possible to recover, and widely accepted that the earlier we get folks connected, the better.